Thank you for coming. My thanks to Kerry and her team, firstly for the invitation and for making me feel so welcome here. I want to particularly thank those who have travelled some distance, and I want to acknowledge, not by name, some of the people I've met tonight who I last saw about 50 years ago. I don't think they're following me around, it just is one of the serendipitous things that happen, I suppose, in most people's lives, but it seems to happen a lot in my life, and I think it's because I would have to say, passionate about death and dying, and please don't be overawed by that. And I hope after tonight you might understand why I'm passionate about it. But I think people who've been touched by death and dying within families, or who have friends or family living with a life-limiting illness, they are searching to understand not only what is going on with their sick loved one and how they can best be there for them, but are also seeking to perhaps better understand their response to that situation. Now, tonight, I'm not going to be talking probably about the palliative care that you're familiar with. I would assume most of you have had someone in the family or a good friend die, and they may have received palliative care. If I ask people what's their understanding about palliative care, what I generally get back, and it's a very reasonable answer, it's around the technology and the medication that we can use to keep people comfortable, the additions we can make within their house to try to increase the likelihood of them being able to remain at home, the social work support, the pastoral care report, expertise, and it goes along that vein. In other words, what we can actually do for them. And I'm not underestimating the value of that. We ourselves, when I say we, my wife Anne and I, have cared for parents at home when they were dying, and at that time I was not a palliative care doctor, but I was a consultant physician in a country town, 2 country towns nearby here, Lismore and Armidale. And I felt I had all the skills required to look after people who were perhaps dying. And Anne, my wife, is a double certificate nurse, so I thought we'd be a good team. We floundered. There was medication, and the medication often was helpful, but it also had its problems. It wasn't uncommon for my father-in-law to be sitting on a couple of runs up the steps going to our first floor, fishing, casting a line out. He had nothing in his hand, but he was casting a line out. I was totally flummoxed as to what that could be, and it ultimately turned out to be medication-induced. And that's the aspect of palliative care I think most people are familiar with. There's also a fear around palliative care. The very mention of it, it particularly frightens family and relatives, perhaps more than it does the person themselves. Only because most people equate palliative care with I'm dying, I must be dying. And palliative care is therefore reserved for people who are dying. I think palliative care has probably created that misconception because when I first started in palliative care in the late 1980s, we only saw people who had a life expectancy of 3 months or less. If it was thought they were going to live longer, we couldn't reach out to them, not so much because we couldn't offer something, but we were stretched. There were very few palliative care doctors in the 80s, so essentially we had to limit the number of people we could see, and one way of doing that was to see people right at the end of life. And that impression has carried on simply because we haven't been open sufficiently for people to understand palliative care is not based on how long we think someone is going to live. It's based more on the fact that they have an incurable illness, which may or may not be cancer. These days it's often chronic heart disease, chronic lung disease, dementia, neurological problems, motor neurone disease, for example. So we see a whole vast array of people with different illnesses. And the other thing that we try and impress upon people, it's not how long they're living, it's more about the quality of their life. So if someone has a life-limiting illness and is being cared for so that they're comfortable physically and they're able to do whatever their illness allows them to do, the GP is the best palliative care doctor you can get. We get called when there are issues that are seemingly difficult to control, and our job is to try and improve the quality of their life. We don't. Let me put it another way. The treatment we offer may extend the length of life. That is questionable, although there is research now that has shown that groups of people with a certain disease who receive active treatment, meaning continuing chemotherapy or radiotherapy, and another group of people with exactly the same illness and at the same stage receiving palliative care, the results are now in that show that the latter group actually live longer. But we're not recommending palliative care for people who want to live longer. What our goal is to make whatever days, weeks, months or years of life they got left the best quality of life, so they can do whatever their body allows them. That is what most people think about, hopefully, what palliative care is now. The area I'm interested, however, is an area that's poorly understood and unfortunately often mismanaged. And it's essentially got nothing to do with their illness or how close they are to death. When I started palliative care in the late 80s, I went in there as a consultant physician, did my best to improve their pain, their breathlessness, their constipation, and I'd go through a whole list of questions which should be dealing with those things. And after I'd seen the person concerned and altered their treatment, if it was necessary, I felt my job was done and I'd go to the next patient. And that would be my routine until I started to be challenged. And the challenge came not from physical problems, but from psychosocial problems. Their fear of dying, their concerns about their loved ones. You can imagine what might go through the mind of people, and it depends a bit on their age and how well they're prepared for their death. But they would often bring it up with me, and I felt totally inadequate. And that inadequacy was highlighted by my training as a pastoral care worker. I took time off work as a physician, palliative care physician, to do pastoral care, which is essentially listening to people. Not doing anything, but just listening. And I found myself paralysed when I was with people who were struggling emotionally or with existential issues around their dying. I was aware of the struggle, but what shocked me most, I needed to be able to write a script, and I couldn't do that because I wasn't acting as the doctor. Or I needed to write a consultation for this person who was depressed or fearful about their dying, a consultation to see a psychologist or a psychiatrist. And I thought, what's happening here? What skills do I need? And I ultimately found the skills that I need, not to say that I'm a good pastoral care practitioner or any better a doctor, but I found there was nothing I had to do but listen. The reason is you can't solve these problems, you can't cure them, you can only hear them, and it's in the talking about their problems that people will find healing. In other words, by healing I mean a sense of peace around their dying. But it became stranger than that. They started talking about things that really I started to question. Now, what I started to become interested in is people started telling me about their strange dreams. I got even more concerned when they were talking about people they were seeing and wondering, is it my medication that's doing this? Are they delirious? And if I didn't wonder about it, their family certainly did. And you will soon see what I mean. I also became interested in the phase of unconsciousness. Most people, certainly in the older age group and in the palliative care situation, I'm excluding, of course, motor vehicle accidents, sudden death from heart or lung disease. Most people who have a chronic illness, whether it's cancer, dementia, heart disease, lung disease, will go through a period of what's called unconsciousness. Perhaps the one thing that prompted me to get into palliative care was a young man who came to see me when I was in private practice in Armidale. He had been diagnosed with and treated for probably 1 year or more for leukemia. And he came to see me in Armidale and said, I know I've got leukemia. They've tried everything. Nothing has worked. I know I'm going to die. And I've come to see you to get your agreement that when that time comes, you will do nothing to prolong my life, but you will keep me comfortable and let dying run its course. Now, it was almost less than a week, and he actually was admitted to hospital unresponsive, unconscious in your language, and I'll say more about that. Didn't move, bat an eyelid, twitch when we moved him from the ambulance trolley into the bed, and did all the things you do when someone who's on the edge of death comes into hospital, and all that was put a needle in his hand so as we could give him some pain medication to ensure he was comfortable. And I sat down outside and spoke to his family, and said they knew exactly what was happening. He had preempted to them the type of care he needed. And I said to them, with his condition and the problem he's got, which was an overwhelming infection, and he'd made sure that I wasn't going to give antibiotics for that, I said, we'll keep him comfortable, and I expect he will die in the next 24 hours. And his family accepted all that, but what troubled them is his only sibling was in America and wasn't able to get back to Australia for about 48 hours. And I said, oh, that's sad, because I can't imagine he's going to see this night out. Famous last words, go in, no phone call overnight, go in the next morning, he's still alive. Look, his pulse was perhaps a bit thready. His temperature was well over 40. He looked very unwell. And I said, look, I was surprised he didn't die last night, but I can't see him lasting through till tomorrow, which was when his sister was due to arrive. No phone call overnight. I wondered what's happening. I wasn't there at the time, but the family told me. They sat in the room with him while another member of the family collected his sister from the airport. In the 48 hours, he hadn't batted an eyelid, spoken a word, moved, hadn't drunk, and clearly nothing to eat. The family was sitting in the room, and all of a sudden, his eyes opened. And at that very time, his sister walked into the room, and he died that day. What I was interested in, he had knowledge at some level that his sister was coming, and I would say had knowledge of her presence even before his parents did. So the question I had in my mind, what's going on in the mind of these people who are seemingly so close to death? They're just either not there, or there's immense suffering around death and dying, particularly with unconscious people. And some of the things I'm going to talk about towards the end, and I've got to move on to make sure I get to it, is what's going on in the mind of people when they're unresponsive. But before we get to that, I'm just going to go on to, I think, slide 5. This is to illustrate, it's a metaphorical interpretation of palliative care. The iceberg, the bit of the iceberg above the water, what we can see is the illness the person has, that's visible. The symptoms they have may not be visible, but can be vocalised. In other words, it's all apparent. But it's what's under the surface that is the big problem. When I say problem, it's what people face. And the definition of palliative care that I like, which speaks to this, is that we firstly make the body a comfortable enough place to live in, quality of life, the top of the iceberg. But once we've done that, and they're comfortable, that's when all the unconscious issues, the regrets, the concerns, the fears will come to the surface. And it will, unless you have done a lot of work beforehand. When I say work, talked about this. But I just don't want to, at this stage, go into that. But you might want to ask questions about it during the next session. What I'm aware of, however, we as a community find it very hard to be with people unless we're doing something. Just like I found it very hard to be a pastoral care worker because I couldn't do anything. What we now know, people who are comfortable do want to talk, but very few will listen. And if you read enough books written by people who are dying, the word or the major issue that they will talk about is loneliness. And it's not loneliness in the sense that no one is visiting, but it's loneliness in that no one can hear my cry for help. I'll just, perhaps that was stressed particularly by an author called Corey Taylor, who wrote the book Dying, a Memoir, and it's so powerful, this sense of loneliness she felt, that it's part of the reason I'm here talking. On that point, the knowledge I've got and which I'm imparting is not knowledge I've got from books. It's knowledge I've got from sitting and listening to people as they taught me what it's like to die. And because they can't tell you or anyone else, I am desperately trying to be their voice and saying how important it is to listen. So the next slide, all these pictures are Google pictures, but I've chosen them because they remind me of the person I cared for. All these stories that I'm going to give are real stories and they're people I cared for. Maria was an Italian matriarch. She was the grandmother to numerous grandchildren, almost as many, numerous great-grandchildren, almost as many grandchildren, and she had 4 or 5 living children, her own children. She was admitted to hospital. She had very late-stage cancer, but the family had cared for her at home beautifully, but it got to a point that they just weren't able to manage, so she came into hospital. This woman couldn't speak a word of English. She was Italian. The family stressed to me in private when she came in that they knew her mother had cancer, but they hadn't told her that she had cancer and insisted no one else tell her, and certainly not to use the word dying. Not that she would have understood it in English, but the family just never talked about death and dying. This woman laid in bed as depressed as anyone could be. And every day the family would come in and be jolly, and this is no criticism, it's just fact, encouraging her to eat, and she ate very little and didn't join in the banter that was going on. After a couple of days, might have been longer, and nothing had changed, one day on a ward round, the family came out and virtually grabbed me by the collar and said, "You must come and see my mother because she wants to leave hospital. And she obviously can't because she's too sick and she's dying." And I wondered, what's going on to make them say this? So I went in there. And this woman, who had virtually spent all of her time laying prone in bed, was sitting on the edge of the bed, gesticulating in Italian and doing this. Just totally, in total contrast to the woman I'd seen in the previous several days. So I said to the daughter, "What is she saying?" I haven't put it up there yet, but you can. This is what, and this is absolutely verbatim. "My boat has come, my bags are capped, I'm going on a beautiful journey, but none of you can come with me." If you had a relative close to you who said that, perhaps I won't take this audience because perhaps you're slightly different to the general community, but what most people would do is what this family did to me. They again said, "See, I told you she wants to leave hospital, you must give her an injection." I took the family outside and said, "She knows she's dying. You may not have told her, but she knows. She's not talked about dying to you, I think, because she knows it's creating great distress with you. But what she wants most of all, as does any person who's going on a long holiday, is to say goodbye and to be hugged and kissed." From that moment on, they talked about death and dying. They talked about how much she was loved, what a wonderful person she'd been for all of them as children, for the grandchildren and so on. She died about 2 days later. The family came in to thank us with, in typical Italian fashion, food and flowers. And the thing they said, "We so valued those last 2 days. Thank you for letting us know." I'm telling you about this, and I think you would probably be as receptive as I am to this information. Sadly, this type of language, up until recently, was treated with an injection. It was seen as delirium. We now know this was a dream that was so powerful, it became a vision. In other words, it virtually woke her up from her depressed state, and she was on the bed because she could see, presumably, a boat. But it's not well known, and it's only been in the last 10 years, I'd say, for palliative care to accept it, and it's only now being accepted in acute care hospitals that this happens. I'm not boasting, but I worked with the group, the Palliative Care group at St Joseph's at Auburn, and we published, I won't say the first paper, because the first paper published on this was a book written 100 years ago, but had been forgotten. We published, or attempted to publish, stories like this, and saying, there's a real message here, what are we missing? There's something we're not doing. We got a reply back from the journal which said, "Oh, that's very interesting, but it's too fringy for us." Fortunately, there was another palliative care journal, and they published it, and I'm not saying we had a great influence, because we, in the type of work I do, it's face-to-face. We haven't got a large research unit and not known in the medical world. But the only way we can get this message out is just keep talking about it and talking about it. So the point I want to make, the fear of talking about death with people who are dying is generally coming from within us. My belief is most people who are dying know they're dying. I won't say all, but most. You'd have to be blind Freddy not to know. And they don't talk about it because they realise their family won't talk about it, and they're so gracious that they don't talk about it for them. There's a true story, but this is not a patient of mine. A palliative care doctor did a house call to see an elderly lady who was dying. She was met at the door by the daughter, who said at the front entrance, "I know Mum's got cancer, I know she's dying, but don't tell her. She doesn't know. If you tell her, it'll kill her." And the ethics behind this is, if it's a family belief or a cultural belief, we have to abide by that. But if the person themselves asks, we are obliged to tell the truth. The daughter waited in the lounge room. The doctor went into the bedroom, sat down on the bed, and the woman said, "Look, before you start, don't tell my daughter I've got cancer. If you tell her, she would die." So that's the irony of it, and it's humorous, but it's sad. The conversations you have when you're dying are the most important conversations you will have in your whole life. And if fear is stopping us, it's disastrous for the person that's dying, and it leads to great regrets for those that are grieving. Okay, a little bit more about dreams. I'll talk about Rose, and her name was Rose, but again a Google image. Rose was thought to be in denial. She had advanced melanoma and lived alone and was unable to manage. She initially attended our outpatient department, and everyone was trying to get her to recognise the fact that she was dying, but as soon as she'd start that conversation, she just would turn off. When she was admitted, I was told by the nurse that you must try and get this woman to see that she's dying. And at that time, as naive as I was, I tried, no show. So we all felt this woman was in denial. One day, she said to her daughter, "I dreamt about Tony last night." Tony was a husband. They'd been married for, I've forgotten now, but 40 to 50 years. And every Saturday night, they went out dancing. So when she said to her daughter, "I've had a dream and Tony's going to come tonight," the daughter said, "And what are you going to do?" She said, "I think we'll go dancing." Tony had died of a heart attack 3 weeks before, and that was one of the reasons she was admitted to the hospice. She wasn't in denial. She knew she was dying. We were trying to meet our ends by getting her to talk about it. She was doing it her way. To the point, I say there's no denial. People are doing the best they can at the time. And if that's the best for them, we should leave it like that. We're not denying them anything. They're making that choice. I had a lady, a woman who I got to know very well. She had great difficulty in falling pregnant, and at long last she fell pregnant. At about 3 months in the pregnancy, she was found to have a tumour of the parotid gland. And she was told that unless she had chemotherapy, the cancer would grow and she would die fairly shortly. That would mean the child would probably need to be aborted because it was in that period when it could be. And she said, definitely no. I want to have this child. And she did have the child. The cancer had advanced, and by the time she gave birth, the cancer had spread. She still was able to care and feed the baby and do whatever was necessary. At about the 6-month mark, when she was very unwell, she said to me, I want to go to South America. There's a healer there. And I thought to myself, why would you want to go there when your life is limited and your child is so important? But she did go. She was insistent on it. I can't remember my stance, but I was the one who had to get permission from Qantas to take someone who was oxygen dependent. So I think she gave a very convincing argument for me to do that. And she went there and came back and she was no better. And I said to her, now that you've been there and come back and your cancer's not cured, how do you feel about that time away? She looked at me as if to say, you stupid man, I didn't go to be cured, I went to be healed. And the healing for her was to come to terms with her limited future, but it was also because she'd been estranged from her parents. After she came back, she was over a fairly quick period of time, she was admitted to the hospice because of breathlessness. She arranged a party at the hospice and a family came, and there was tremendous healing in the family. She died not long after, and the effect of that trip and the you might say the Last Supper she arranged with the family led her to a point where she surrendered unto death. But there was one last thing she wanted to do, and that was to create a memory box. And it gave her time to create a memory box when people wrote stories about her for her child to be able to read at some stage later. And I was privileged to be one of those people who wrote something about her. Man on the left was having nightmares. He was a Vietnamese vet, Vietnam vet. And he was the only person in his group of 12 soldiers who survived the war. All his mates died in battle. He was nearing death, and like this man, he had a tracheostomy, couldn't talk, but he would write, because it got to the point I realised how important dreams are. So apart from checking bowels and breathing and all these other things, I would always finish, have you had any dreams? And if so, do you want to share them? And he said he's having recurrent nightmares. He's seeing his buddies and he's dreading having to face them and explain how he alone survived. And he was petrified of dying, not because of death itself, but what this dream was telling him. And that went on for a couple of days, and each day, and he was having this nightmare every night. And every morning he was even more distressed about it. After about 4 mornings, it was totally different. He was, if anything, you would say, happy. And I said, what's happened? He said, I now know what it's all about. They're not waiting to harangue me. They're waiting to welcome me back. The point about this is, in this case, it took him a long time to come to some understanding what that dream was. The point being, Healing comes from within. The person who's having a dream, they have to interpret it. It's no point us trying to put an interpretation on it. The second thing is they often revisit whatever the problem is. In his case, it was the dream that was troubling him. It might be a man who regrets something they'd done, or a woman regrets something they didn't do during their life. The important thing is to let them talk about it, and let them talk about it, and let them talk about it. It's often said the best therapy for regrets around death and dying is not a pill, but to allow them to keep revisiting it. They will then have talked about it to the point they can let go of it, and with that comes a sense of peace and equanimity. Now we're getting onto the strange part. These are dreams that you might think makes a bit of sense. This young girl had been sick all her life. There was one illness after another, and ultimately she developed a life-threatening illness. And she was the sad... I don't look after many children, but she was the saddest kid I've ever seen. Her whole life was spent in hospital or seeing doctors or on medication or various forms of treatment. She became extremely fearful of death. So much so, she wouldn't sleep in her bed, and the family, of course, the husband and mother and father, brought her into their double bed, and she slept with them every night. But every morning, the father got up to make his wife a cup of tea and took note of his daughter, and she always looked, if she was awake, very sad, but sometimes she was asleep, but nothing special other than a sadness about what was happening. One morning, when he woke up to make a cup of tea, she was sitting up looking out of the window and smiling. And he thought, oh, this is good. I'll go and make a cup of tea and come back and see what's happening. When he came back, she was dead. They struggle with that. And for better or worse, I said, my experience is when people are dying, it's not uncommon for them to see something that really excites them. Adults, it's often visions of a predeceased relative. With Maria, it was something to do with travel. And a lot of these weird dreams close to death are the commonest features of the dream is a predeceased relative or travel. One, I think we've got it here, but if we do put it up, a woman who said, my mother's here, my bags are packed, but I don't know which plane to catch. A bit like Maria, but Maria knew exactly where she was going. That is a situation when you just let them talk about it. In Eve's case, although there's no proof, I said to the family, my belief is she had something that made her feel happy. I don't know what it is, but the fact she had a smile on her face and she died so quickly is the most likely explanation. I didn't say that to try and cheer them up. I said that because I honestly believe that's what happened. We now know these visions around death and dying. This is the research that's coming out of America. 80% of people who are approaching death will have one of these dreams, and if the dream is profound enough and moving enough emotionally, they'll actually wake up with it and the dream continues. And it's when, if they do get the chance to talk about it, up until recently, we've either brushed it off, ignored it, or treated it with a drug. the dream is still of immense value for the person that's had it, but the family can't share in that joy if we're brushing it off as delirium. In fact, it makes things worse for the family to think that their relative is now delirious. And if we ignore it or misinterpret it, the value for us as family and staff caring for people is lost. Again, the reason why I'm here talking. I don't expect you guys to be experts in when you're sitting with family members. You need to just be someone who's compassionate and prepared to listen. The job of being with people who are dying is not what you do, but it's how present you can be and be comfortable with whatever comes up, even if that is silence. Because let me say, these visions and dreams certainly come when someone's asleep, but it's just as likely to come when they're daydreaming. So you respect those times. I'm not necessarily going to encourage you, but I found when I started asking people about their dreams, it was almost as if they got excited about it. Here's a doctor who's not just asking me about pain in my head or pain in my butt. He's asking me about something that really interests me. Got to be careful, but it's got a lot to do with your relationship to that person, your connection with them. You've got a good relationship, there's a trusting bond between you. It's safe to ask those type of questions. Trent was a young boy, heavy drinker, captain of his football team, always seen, had a full room of footy blokes. One day his dad visited him in the afternoon. The room was full of blokes, but they were all sitting on a chair, but there was one empty chair. The dad thought, I'll go and sit on this chair until the blokes go, and then I can chat to my son. As he was about to sit down, his son, who was dying, said, Dad, don't sit there. Dad said, why? He said, Trent's sitting there. If you were the relative and someone you knew and loved said that to you, you would probably do the next thing what the father did. He chased me up and said, you're giving him too much morphine. You need to cut the dose down. And he told me what happened. And I said, wait in the room, but when all the visitors go, call me and we'll go in and chat with your son. We did that, and father said to his son, tell me about Trent. Don't remember the exact words, but the message was, Trent's been here all this time and he's showing me the way out. And such relief for the family. Found it very hard to deal with it, but eventually it gave them some sense of, I won't say joy, but some sense of relief that how well he was coping with it, and he was coping with it well because of this person who he didn't know but called Trent had come to help him through this final phase. This happened in the beginning of this century, in the early 2000s. This lady was dying from cancer. Nothing untoward, things were happening as expected. She died. I hadn't seen her that day, but I went the first thing the next morning. And the husband, I went to just be with the husband. He was really quite agitated, and I thought it was because of the death of his wife. And he said, no, her sister had told him something, and he's struggling to come to terms with it. And what she told him, this woman in her pre-teen years had a life-threatening acute illness and was thought to be dying. what she told her sister just prior to her death at age 42, she had a vision in that dream as a young kid, and the person she saw said, "You're going to survive this, but you will die at age 42. This is the mystery we're dealing with. I don't pretend to understand, but there is immense value and teachings in what people who are dying are trying to communicate to us. And as I said, I feel almost a sense of responsibility to speak for them. And I'm pleased because there are more and more people becoming interested in it, wanting to learn more about death and dying because it's a real mystery. And the kind of side of dying comes from, and I slipped by it on one of the first slides, certainly making their body a comfortable enough place to live in, but by creating a space where the person, if they so choose, develops enough courage to talk about the type of things that are either troubling them or may share the type of dreams that we now know to be almost universal with people who are dying. Just, I think, just to preempt what we can talk about after the break, can we just go to number 14? Now I'm talking about all the ones people I've spoken about were conscious and able to talk. What about people who are unconscious? What's happening with them? And that has been a particular passion of mine for the last 20 years. To know what's going on in the mind of people who can't tell you anything because they're so close to death, they're unconscious. The first thing I say, and I am going to watch the time carefully, they're not unconscious. They are unresponsive. They're not moving, they're not opening their eyes, not talking most of the time. But for the early phase of this period, they have a varying degree of awareness of what's going on around them and with them. They can experience pain, they can hear. Those senses are working. So they can hear us talking, they can feel what the nurses are doing, what the doctors are saying, what the doctors are doing. And for that reason, when we're with people who are unconscious, you treat them as if they're there, they can hear, they may not see. So we never talk about them, we talk to them, and we tell them what we're doing, and we encourage family to talk to them, not harangue them constantly, but just to let them know you're here and to validate them how important they've been in their life. So that phase of being connected to the outside world goes on for a variable period of time, but it gradually wanes. The sicker they get, the less connected they are to the outside world. And their awareness is profound. And why we know that is because if you talk to people who've been unconscious because of a coma, let's say a head injury or a stroke, research has been done. Those people who survive a period of coma, they're being asked, what do they remember? The detail they remember is amazing, and sometimes it's a bit twisted. There was a man, when he woke up, was surprised he wasn't in a railway station. He said, I was hearing noises and I was convinced I must be by a railway station. Later that day he realised what it was he was hearing. When the nurses were wheeling the trolley around the ICU, the noise it made, his only assumption was it was a train. So it just shows they can hear. I talked about my man with leukemia. He was lucid in a sense right up to the time he died, lucid enough to know when his sister had arrived, but he didn't show that lucidity other than opening his eyes. This lady, I was bowled over. She was dying at home. I was called in as the palliative care physician to make sure she was getting the right dose of treatment, she was comfortable, and the family were coping. And all that worked out, and I said, I'll now leave it to the GP, but I would like to ring each morning to see how things are going. When I left, she was totally unresponsive. When I rang the next morning, they said, nothing's happening, just as it was yesterday. Thank you for ringing. The next day, how's your mum? Oh, she's up drinking champagne. True. They heard the pregnant pause at the end of the phone, and they thought, oh, but doctor, of course you don't know. Today's her birthday. We've been telling mum, your birthday in 2 days, your birthday tomorrow, today's your birthday. She woke up, did have a glass of champagne, went back to bed and died that day. That's called a lucid period prior to death. But we also know people can have visions. That lady on the right, it's a Google picture, but I was one of the privileged people to have seen someone have a vision just at the moment of death. She was so close to death, I was afraid the family wouldn't get there to see her before she died. And I sat with this woman while the nurse rounded up the family. She could hardly draw breath. She was skin and bone. She hadn't moved. And I was just sitting there, God knows what was going through my mind. And all of a sudden, this woman sprung up. Didn't struggle to get up, she sprung up just like that, and she did exactly as that woman was doing. Stayed in that long enough for the family to see it, and I subsequently explained what that was about. She laid down, and no sooner did her head hit the bed, she stopped breathing. So my interest, and why I talk about the kinder side of dying, there are things that happen around death and dying that we can't explain. It's mysterious, but it does bring a sense for those who are still conscious, a sense of peace and equanimity, and there's less fear of death. And that is helped if we can get them to talk about it. It still helps if they don't, but if they talk about it, it seems to just facilitate that healing can occur. And the point I'm trying to make is this goes on right till the moment of death. And I think when we come back, I'll just show you a couple of pictures. And if my expectation is it'll boggle your mind as much as it does mine and neuroscientists throughout the world. But let's come back. We'll have, how much, 10 minutes or? 10, 15 minutes. Yep. And I would really now like to hear your thoughts. Feel free to ask any question. Don't be concerned, oh, it's a bit too simple a question to ask. Don't be afraid to quiz me on what I'm telling you. I just want to hear your experiences, perhaps your concerns, how you would feel if you were in that situation. I'm not saying I've got answers, but it's just good to share. And if we get 5 minutes at the end, I just want to show you some of the research that we've done on people. And we had their permission to do this before they became unresponsive. What's actually happening during that time, they can't tell us what's happening. Okay? So 10 minutes. Thank you. Let's start with questions or comments. Perhaps Helen's going to...
I have some questions.
Yes.
I have some questions for you that people have kindly dropped off. Thank you, everybody. So this doesn't have a name on it, and it's more of a sharing. I saw angels surrounding my boyfriend before he died. He could not see them. Has this happened to other carers?
Yes, and I'm not sure how common it is. More often it's the person that's dying who's having the vision, but there are some people who will describe seeing things and it's not a shared experience, and the important thing is to live that experience, not to question it or wonder why this is happening, just let it be the guide.
And would you say, Michael, like, I'm just thinking about myself in that situation, you know, would I share that with my person who was dying? If I could see them and maybe they were unresponsive and weren't able to respond, you know, would you share that? What would you think would be, is there a right answer for that, or is it just really what feels right to do?
Yeah, I suppose I always hesitate about giving a generic answer that might be applied, so I think it's got a lot to do with the situation, the relationship, and your intuitive knowing about whether it's something, and to trust that. Not if I had to do it from my rational brain, I think I'd probably get it wrong more often than I'd get it right. So it's your intuition and your relationship from that person and what type of discussions you've had and your sense about what this person, the way they think and how they would respond to it.
Yeah, and I like that thing about really something I've learned as a doula is really about trusting my instincts too, you know, to what just feels right in the time.
Well, the one thing, perhaps I'll use that point to just let people know, the most intuitive people in the world, there are 3 groups. Anyone prepared to offer an answer? Children, yep. The dying.
Dogs.
Who?
Dogs.
Maybe. Although we can get into a discussion here, is it instinct or intuition? But given the time, and I don't want to draw it out, but people who are living with dementia, they are extremely intuitive. Yes. And so don't take things, not that you would, but one of the lessons we need to get out there, you're responding to the persona, to the person that you knew, not necessarily to the behaviour that they're exhibiting at the time, but they are very intuitive. Okay.
Thank you. So does the level of medication affect the frequency of end-of-life dreams and visions? And it has a following on question, are we over-medicating the dying?
I'll take the last one. I think perhaps in the past we were, but I believe we're getting much, much better at it. We're fine-tuning things better. We're aware of the side effects that can occur. But the other thing that helps is the choice of pain-relieving medication now is vast. And if people are either not responding to the one they're on or having side effects from it, the option is that there are several others that can be tried. But I do think we've learned from years of practice, and I do think things are better. I think we still run into problems, but they're far less now than they used to be.
Thank you.
I forgot the first.
The first one is, does the level of medication affect the frequency of end-of-life dreams and visions?
No, I don't believe it does. My interest in it has led me to look into it. What this is, as with any dream, it's the unconscious putting things into visual form. It's the unconscious speaking to us, really, telling us what we either know or don't want to know. So I don't think it interferes with that, but their interpretation might get warped. If I can just stray. I had a lady who I was called to see her because she had intense pain. So intense she would call out, pull up her knees, and she had a rice pack to her tummy. And every time the pain came in waves, she would demonstrate pain behaviour. And I was called to give her an injection. Right? When I got there, and God knows why, I just sat beside her at the end. In fact, I think I was on my knees to be at her level. And I just said, tell me what's happening, which is a valuable piece of knowledge to be able to put out to people. Just tell me what's happening. And much to my surprise, she didn't talk about pain. She talked about all these colours. And eventually, couldn't make any sense of it, but certain colours was associated with pain, different colours, pain relief. And so it was a bit of a nightmare for her, and the thought was, are we overdosing her? And I'm not going to say this works all the time, but I said, based on my knowledge and experience, is there anyone there with you? And she said yes. I can't remember the exact relation. Could have been an aunt, but it may have been a mother. I'm pretty sure it's in the book. And the next question was, do they have a message for you? She said, yes, the message is everything will be okay. And from that moment on, the pain stopped, and she didn't need that breakthrough. So the other story is that I've had people have visions of predeceased relatives, but they were also having hallucinations of spiders on the wall or massive dogs in the room. When we reduced the dose of morphine, the dogs and spiders disappeared, but they were still having visions. So they're different things, but if the effect of the medication is so big, it sometimes can just dilute out the effect of the vision.
Yeah, thank you. This question has a couple of parts to it. What about people with advanced dementia? Do we know if they dream? I think you sort of alluded to that just a moment ago. What is going on in their mind? Is there any thoughts or images? That's the first part. Do we know if they dream, and what's going on in their mind? Is there any thoughts or images?
My instinct or intuition is yes, they do dream, because the part of their brain that is affected is the cerebral cortex, and the dreams are coming from, it doesn't have anything to do with the cerebral cortex. The visual effect is influenced by the cerebral cortex, but the origin of the dream has got nothing to do with the cerebral cortex. So I think the emotional part of the brain, the intuitive part of the brain, and the dreaming part of the brain is much more hardwired than the cerebral cortex. So people who are living with dementia will have all the cognitive problems that you're all familiar with. But as far as their dreaming goes, my belief is that they do dream. Certainly their intuition is probably more finely tuned than ours. And their emotional response, you only have to play a tune that they loved during their adult years and tears will come to their eyes.
Absolutely, or they'll start to sing all the words, amazing.
That's right.
It just reminds me, with my mum, I cared for her for 7 years with dementia and was with her in her last couple of days and by her bedside, and mum had been unresponsive for 48 plus hours, not a move, not a muscle, not a twitch, not an eyelash, nothing, just nothing moved. And right at the very end, mum fully woke up, turned her head, looked at me, right, drilling into my eyes, and was so present. I'll never forget those baby blues. So there was definitely an awakening of some sort, and we're hopeful we get to hear a little bit about that this evening. Yeah.
Oh, well, we may get to it. I hope we do anyway.
Yeah. So do we know about end-of-life experience for people with advanced dementia?
It's certainly not been studied, and I think if it does occur, we're so overwhelmed by the dementia we probably miss it. The reason I suppose I do believe they have end-of-life dreams comes from the fact that we know people who have mental health problems, particularly mental health problems, but in this group I think they also include dementia. They talk about paradoxical lucidity, which means while they're conscious, they have these periods when they're absolutely lucid, and you'd wonder, are they really schizoid or schizophrenic, or are they living with dementia? But in a couple of minutes it's gone. If that happens sporadically during their awake phase, there's no reason why it couldn't happen, or dreams can't happen when they're unresponsive.
Yeah, great.
So my gut feeling is yes.
Yes. 2 more questions I have here. Can you please talk more about NDEs, near-death experiences, commonalities, symbolic meanings?
Okay. I don't profess to be an expert on NDEs, but I believe there is some similarities. But the thing about NDEs, they occur, it's the context particularly is the most significant thing, because with NDEs it occurs with an acute sudden illness or deterioration, such as cardiac arrest, motor vehicle accident, drowning. So it's the context, and it's often a sudden event, but it doesn't have to be, but nearly always sudden, or it can be the thought that something serious is going to happen. In other words, a near miss motor vehicle accident. The most, I suppose, published material on this has been with people who've had cardiac arrests, and what they're particularly interested in is not just the experience, which for them is life-changing. The phenomenology of a near-death experience, in other words, what they see and hear, has got a lot of similarities to a deathbed vision, but also a lot of differences. It's often a tunnel effect, sound, and a bright light at the end of the tunnel, and a sense that when they reach the end of the tunnel, or a bit before, a message that's not auditory, but a sense that's telling them it's time to go back. And so they go back into their body and the event's over. Whereas near-death experience, it's not often a bright light in a tunnel. It's more often visions of people that they often know, but sometimes not. With many of them, it's travel, as I've said. With children, it's often school teachers, animals, or their visions of what God is. Or, again, a common one is a bus, particularly kids who travel buses travel. So the theme of travel and predeceased family is the dominant part of a deathbed vision. But what follows, it's also important, is the sense of peace that it brings in the equanimity despite impending death. NDEs also have a profound effect on those that have it, and their life changes dramatically, and their fear of death is often very small. The only one thing I will say from personal experience, it's just like that. The experience comes on from whether it's a cardiac arrest, drowning, or a motor vehicle accident, or a fall. There's been a lot written about mountaineers falling off the cliff, and surprise, surprise, rather than sheer panic and expectation they're going to be killed, there's this sense of peace that they have. So it comes on. So it's almost an evolutionary phenomenon that's come to protect us around the time of death. I haven't mentioned out-of-body experiences, but they're very common with near-death experiences too.
Yeah, I was just going to mention that there's a lot of people I've talked to that, if you like, are being resuscitated, but they can actually describe to you what actually happened, and they were out, and they were out of their body, and they were experiencing, watching, and then that one went over there, and that person did that, and that one said that. There's a lot of stories of that. You can, research it. There's so much out there about NDEs.
They're still researching it. The one I remember is Peter Sellers. Many of you here might be my age to remember him. He's had a couple of cardiac arrests, and one famous quote was, during the cardiac arrest, he was thinking, I feel okay, but my body doesn't look too hot. You know, he put it in that type of language, and my personal experience has been I was drowning, but I wasn't concerned about it because I wasn't in that body.
You're right.
Yeah. So it's a bit strange. Okay.
So this question is, what is a memory box? And that comes from a gentleman says, I'm an Anglican priest, retired, currently working in aged care residential with much experience of people dying, end of life, sitting beside bed, moments of death, dealing with family. So what is a memory box?
A memory box is often created for people who will not get to know the person that's dying. And the memory box is the person who's dying asks friends, people who know he or she quite well, to write their thoughts about the person that's dying, their relationship to them, what they did, what that person liked, so the children as they grow up, or adults who didn't get a chance to spend a lot of time, can read this. But it can be, in the memory box, things go in there that were of importance to the person that was dying, and he or she in turn puts down why that's important. And at funerals, what's often done these days, it's a ritual. You're placing symbols on a coffin to designate how significant they were for these people, this person's life. Perhaps the only difference with the placement of symbols, it's an object that talks about the people. With the memory box, it's often an emotional feeling thing, what this person meant to them, what they valued in them, a bit about their character, personality, things like that.
The other things I've seen go into memory boxes too are where people, who are dying, they're the ones actually contributing to the memory box as well. Putting in things like, one woman I worked with, she had teenage daughters, young teenage daughters, just 13 and 14, and she wanted to buy them engagement presents and wedding presents so that when they got engaged and married, that mum was there with them. And she left letters and videos and all sorts of mementos, and this is why this was important to me. It was beautiful, just so that they had this thing of mum, with them.
I think that we talk about the kinder side of dying, creating rituals around death, which may be a memory box, but it can be other things around death and dying. And maybe ritual's not the right word, like that woman who died after giving birth to her first and only child, having that big luncheon at the hospice. It was such a healing thing for her, and that's what rituals are about. It's all about healing.
Absolutely. So does anyone else have any questions? We've run through our written ones. Would anyone else like to ask anything or share or say anything? How much time do we have left? Does anyone have a watch on? I don't. It's good. Does anyone know the time? Okay, great. So we've got another 10 minutes. So if no one has, I'm going to get away from the microphones. If no one has any particular questions at the moment, Michael, maybe you could share some of the incredible research you've done.
Okay.
We've got 10 minutes. Would everyone like that? You really would like that, let me tell you. Thanks, Michael.
You're not going to get a no answer when you ask me that question. I talk
I
about
know.
research.
That's why I asked it.
This, to me, is an allegory. It was presented by a woman at a conference I went to in Alice Springs. Angela Lynch was her name. And the allegory goes like this. There was this old Indigenous gentleman walking along a long, dusty road, almost leading to nowhere, and a young guy driving a souped-up ute came along, saw him, and stopped and said, "Do you want a lift?" The guy thought about it and decided, yeah, I'll take the lift, take the offer. Hopped in the car, seatbelt was put on, and off the young driver went at great speed. After a little while, having noticed that the Aboriginal man hadn't said a word, the driver turned to him and looked at him and the guy was as pale as any Caucasian person, and said, "What's the matter?" Because the Aboriginal guy said, "Stop, let me out, I want to get out." "But why? You're a long way from nowhere." "Stop, I want to get out." "Tell me what's the matter." He said to the young guy, "You're going so fast, my body is here, but my spirit is back there, and I need to stop so my spirit can catch up." The motto of this story is that is the danger of medicalising death. So much we're doing, so much we're focusing on the body, and what is neglected, and not consciously, but is unfortunately an outcome, is that we just are not dealing with the real issues, what's below the surface. So the soul, as one of my friends who was dying said, words to the effect, "I got wonderful medical treatment, but my soul suffered because no one directed any attention to that." So that, I just wanted to finish off by saying we need to keep what's good about medical treatment, but recognise that we have neglected what becomes most important for people in their life, particularly when they're dying, is to deal with all the regrets, or perhaps to share the joys that they've had in their life, to be able to talk about whatever it is. When I was in Canberra, because of the experience of that woman who had the deathbed vision, and Ian, the young boy in Armidale who had leukemia and woke up, and also the woman who was drinking champagne, having been unconscious and unresponsive for days before, I wondered what's going on with people who are unresponsive and can't tell us. So we used this monitor on the left, which measures the level of awareness. And the range of scores we get is 100, which is wide awake. 50 is the type of level you would be at if you were having a general anaesthetic, and 0 is brain death. So the monitor was particularly used by anaesthetists to determine the right dose of anaesthetic, and they would try and get that level to about 50. And I thought this would be interesting. I wonder what type of levels we'd get with people who are dying. And so that's you can see where the sensor goes on the forehead, and it's connected to that machine. I'm going to tell you the type of things we found. We firstly found that most people, when they were not responding, you would call unconscious, I call it unresponsive. And I make that distinction because just because they're not moving doesn't mean to say they're not there. The first thing we noticed, most of them had a score around 50. The question is, do they hear? This was just what we call a pilot study to see if we could get any useful information. It so happened the first person we connected it to, I asked the family to wait outside because I thought if the machine doesn't work, I didn't want their anxiety to be raised. So I said, look, just wait outside. It'll only take 5 minutes and I'll connect him to the machine and then call you back in. This young boy, he was about 30, was dying of HIV, and he was totally unresponsive. No sooner had I connected the machine that the bedside phone rang. Now, normally you would say, bugger it, it's disturbed him. But this was a blessing in disguise, because what happened, the machine, which was 50, went up to about 90. So something happened. He either heard it, whether he recognised it as the phone ringing, I don't know, but the sound they can hear. How clear it is, or whether they can make any sense of it, I say we don't know, but researchers, people who are experts in hearing, say up to a certain point, yes, they can recognise what it is. I called the family in and told them what happened. I said, yes, we got the machine connected and the result suggests he's really comfortable, level of 50, as you would be with an anaesthetic. And then I told them about the phone ringing. And his mother, or actually it was a family member, because the mother was Spanish and couldn't speak English, and the family member said, Mum asked, if that happened with the bell, the phone, would it happen if I whisper to him? This is the score. The line to the left is probably it's 55, and that bump is when the phone rang. It's almost 100. So it really shook him up, and he maybe recognised it as a phone call. The gap in between is when I was speaking to the family. The next one is when the mother spoke to him. So evidence to suggest that people who are unresponsive are aware of what's being said to them. And for that reason, when we're sitting with family and their relative who's dying is unresponsive, we make certain comments. Firstly, when you go to see them, tell them who you are and that you're staying there. Because if you don't, sometimes they're uncertain and they've got to try and orientate it. But if you've made that point clear, they can immediately relax if they can hear it. You never talk about them. You always talk to them as if they can hear. And the other thing is to validate them. We could go on about this, but I'm getting time's up. But that is an important lesson, that people in the early phase of unresponsiveness are in fact able to hear and feel touch. So we talk about keeping a connection going. The last thing I'm going to tell you about is just the mystery moment of death. 50, and it drops right off to almost death. But before death, there's this sudden spike. And the big question is, what is that? And let me say, throughout the world, no one is prepared to come out and say. Neuroscientists say it could be just the dying brain. Other people, myself included, can say it's possibly a death-bed vision. And there's now more evidence coming out to favour the latter, but still not general agreement. But it explains to me how that lady that I saw sat up, was looking at something, laid back down, and immediately died. Okay, so I think I'd better finish, leave you with that to ponder. Death is not something to look forward to, but there are things that can happen that can be very nice to you and gentle and make the death kinder. So thank you very much.